we talk about autism spectrum disorder, the very first thing we need to think about is that it is a neurodevelopmental disorder. It is something that affects brain function, right? We are still trying to figure out all the ways in which it does affect development early on, but we know that it occurs early in life and that it has developmental consequences. So we really need to be thinking about this not as something necessarily that develops over time, but something that has been present and manifests itself in different ways over time. But it does affect brain function from a very early age. And there's two kind of core areas where we see kind of these symptoms manifest. One that has to do with social communication, how the individual talks and relates and interacts with others, and then in the presence of restricted and repetitive behaviors. And we're going to break this down just a little bit. But when we talk about the spectrum, we have autism spectrum, right? And so we really need to talk about what does that mean? And there is a spectrum of symptoms, and those symptoms vary in a variety of different ways, which is why we call it a spectrum. In severity, in number, how many of these different symptoms that are related to autism spectrum disorder are present across time. Things do change and do develop over time in different ways and between individuals, right? So not every individual on the spectrum is going to be the same. In fact, they're quite different from one person to the next, just like we all are. So there's very unique presentations for each, and that is why we call it a spectrum. So we have also a spectrum in terms of how many supports this individual will need, depending on where those symptoms are in that spectrum. So again, when we look at our diagnostic and statistical manual, our 5th edition now, that defines what autism spectrum disorder is, we're talking about these two main categories. We're talking about deficits in one area that has to do with social communication. So the absence of certain behaviors and certain communication strategies that should be developing, that develop differently or don't develop for that individual. And then the presence of things that we usually don't see or that we see less of and that end up impairing function for this individual. So these restricted and repetitive interests and patterns of behavior that kind of get in the way of the person being able to go about their life and that are really the ones that tend to impact the most when we're talking about crisis prevention. Some of these behaviors are the ones that really can significantly impact their relationship and their ability to understand the world. There are two qualifiers that we need to add when we talk about, the individual, if they meet diagnostic criteria for autism spectrum disorder. We also need to indicate whether there's intellectual disability associated and if there's a language disorder associated. And we need to indicate how many supports in that spectrum that I showed you before of the little guy sitting there between levels 1, 2, and 3, those levels are really not levels of severity. They really have to do with how much support does this individual need today in order to function to the best of their ability. And it really just helps us to plan for this individual and plan for helping target the interventions the best way possible and the most individualized possible. So this is our DSM, and we have, again, these deficits in social communication and social interaction, and there's 3 different criteria that need to be met. All 3 need to be met in order for us to talk about an autism spectrum disorder. And within the domain of restricted and repetitive patterns of behavior, we also have 4 different criteria, of which at least 2 need to be met. Again, the symptoms need to be present in early childhood. They need to cause clinically significant impairment in functioning. I always bring up, I think one of the major issues that happened, at least in my experience, when we had the DSM-4, where we did not have this as a specification, is that any little thing all of a sudden became autism, right? So if a child flapped once, or if a child was a little bit more rigid or had a few tantrums, then all of a sudden, people were thinking beyond, maybe just temperament or personalities, or, all of us can be a little bit more rigid, less rigid, more social, less social. There's there's spectrums within all of us as well, and not everything is pathological, right? And so if we are going to give a diagnosis, we really need to be thinking about beyond, personality traits. We need to be thinking of how much does this really impact this individual's functioning. And I always talk about my grandmother here, because she's the sweetest person I've ever met. We had a beautiful relationship. I miss her dearly. But she was one of the most rigid and ritualized people I know. I could walk into her house blindfolded, and I would know exactly where everything was. I would never trip on anything because it was always going to be in the same spot. I knew exactly where to find the pen. The pen was right next to the phone, on the little table, right next to, the entrance to her bedroom, and where the scissors were on the top right hand side of the drawer in the kitchen. You knew exactly where everything was going to be. And she really functioned this way. She went to the supermarket, the same one, every day at the same time, and bought the same few things. I'm from Argentina, so at that time, 8 o'clock was our evening news. And I could set my watch to her sitting down to watch the 8 o'clock evening news, right? And she would have it with her little whiskey, which I prepared many times, 3 ice cubes and 2 fingers of whiskey, 5 little crackers and 5 pieces of cheese. This was her thing every night at 8 o'clock. Now, if I showed up, 8:15 or 8:05 or quarter to 8 and said, Grandma, do you want to go out for dinner? Or do you want to go out for a walk? Or do you want to go to the movies? She would leave her whiskey, her cheese, her 8 o'clock news show without hesitation, right? This was not something that she had to do. It's something she enjoyed doing, and it was part of her daily routines. But she was very quickly able to move and do something different if the opportunity arose. The same is true if her preferred supermarket was closed, she would just find a different one. If the route that she usually took, there was construction, she would just find a different route, right? So even though she preferred to do things in very ritualized ways, this is the difference between a personality trait and something that impacts functioning, right? So here we're really talking about these things to the extreme where they really do impact how an individual is able to manage in their day-to-day. And we really need to be careful that symptoms are not better explained by intellectual disability. So in the social communication bucket that we were talking about, there are these deficits in social emotional reciprocity. This is that back and forth that we have in social interactions. It's what allows us to interact successfully with others, right? So within that, we have issues like abnormal speech approach or failure to have these back and forth conversations, reduced sharing of interests, emotions, or affect, sharing with someone else what I'm interested in, or sharing in somebody else's interest in addition to my own. And then this failure to initiate or respond to social interactions, not understanding how to approach others and how to respond to the approaches of others. So the second criteria that needs to be met within this social communication domain is deficits in nonverbal communicative behaviors used during social interactions. And that has to do with language development and the use of language during interactions, nonverbal communications, so everything that has to do with eye contact, facial expressions, gestures. How do I use these things? Body language. How do I use this to regulate the interaction with others? And it's both what I do to help the other person be able to interact with me, and how do I understand all of the cues from the other person to make this successful, right? So by having these deficits, people with autism are really at a huge disadvantage because they're missing out on all the cues that help them understand how this whole thing works and what's relevant in a particular situation. The third criteria in social communication is these deficits in developing and maintaining and understanding relationships. And this really has to do with, it's a cascade. If you're not understanding, you don't have that social emotional reciprocity, you haven't developed the right skills to have those nice back and forth interactions with others, it really impacts how you're able to develop relationships with others. And so we see this in a variety of ways: difficulties adjusting their behavior to the social context, difficulties in sharing imaginative play or friends, and then the absence of interest in peers. The second domain is this restricted and repetitive behavior domain. And the first criteria is stereotyped or repetitive motor movements, use of objects, or repetitive speech. And this is what often people think when they think of autism, but this is just one of these challenges within this area that we see, whether it's the motor mannerisms, like we see in some of these pictures, that are called stereotypies sometimes, these motor movements of the hands and the body. Lining up of toys, lining, categorizing, putting in, taking out, turning on, off, these sort of things. So more repetitive play. Echolalia, meaning repeating speech, or just using odd language. One of my all-time favorites of kind of a different use of language is a boy that didn't call shorts shorts, he called them pants with knees. So it's a very different way of referring to something. He definitely knew the word, but he had his own way of saying things. The second criteria is insistence on sameness and being inflexible. So being my grandma, but to the point where she couldn't be flexible, right? So needing to take the same route, eating the same food, very distressed when small changes happen and difficulty transitioning away from things that they're engaged in. Rigid thinking patterns or greeting rituals, all of these things are part of that insistence on sameness. Like we see here in the pictures, you know, to be able to go to sleep, this little girl needs to line up her her little stuffed animals and dolls in a very particular way. Or the boy that's really interested in trains and that's really all he draws in a particular train. Restricted or repetitive behavior, the third criteria is highly restricted fixated interest, like we just saw of the boy, but also maybe it's something unusual, you know, like collecting particular rocks or playing with things in a particular way or a particular topic or really, really high specific interest, or sometimes unusual, like fans, right? And these things interfering again with their ability to shift away from this topic and be interested in other things. And then the last area is this hyper or HypoReactivity to sensory input. This is the ability to tolerate and process different sensations from the environment, whether it's through the eyes, smelling, the mouth, taste, hearing, touch, movement. There's a variety of different ways in which these hypo or hyper reactivity can happen. We often see indifference to pain and temperature, very adverse responses sometimes to specific sounds or textures and things that usually don't bother other people, right? This is to an extreme. It's not being upset with a really loud siren or a really loud alarm. You know, that could be bothersome for many people, but it's, you know, sounds that typically don't impact others. And then being really visually fascinated with lights or movements, like we see with the little boy in the middle, who's peering out of the corner of his eye and looking at how the helicopters, I'm forgetting the name when it spins, and looking at that. So why is this really important? Because your next patient may be autistic, right? And it's really important to know what is it that, you know, what does that mean? And how do I use that information to my advantage? And this is where I'm just doing a little sneak preview to Dr. Sorensen's talk, because she's going to be highlighting this so much more and with so many more examples. But understanding what we just talked about, understanding the difficulties, and, you know, and what difficulties an individual with autism may be impacted by when they are approaching you will help you better navigate that situation, right? So they might have unusual or extreme reactions to minor situations, and it could be because of sensory difficulties, or it could be because of changes in routine. It could be because of lack of communication. Any one of those characteristics that we just reviewed can be playing a role in them having reactions that one would not expect in this particular situation. Sometimes it's just engagement in compulsive behaviors and needing to do things in a particular way, and you're disrupting that routine by doing something different or doing something in a way that they're not expecting or they hadn't planned for. Engagement in repetitive behaviors, needing to do something over and over, and us trying to, for example, do a physical exam, disrupting a repetitive behavior, and that can lead to some challenges. And oftentimes, the physical component is without intent. They don't mean to harm. It is, this reaction sometimes to different situations. But, as a provider, one needs to be prepared. So just kind of some tips and tricks to make the visit more successful. One might be just to, if you know that your next patient or someone that you're going to be seeing does have autism, is reaching out to the family beforehand and having kind of a pre-visit chat just to check in. And it can make a huge difference. You can consult with the parents, like what works for this particular person. Are they verbal? Are they not verbal? How much language do they understand? Not only how much do they use, but how much do they understand? They may not be able to communicate as well as they understand. And so assuming that just because they don't speak, they're not understanding could be a huge mistake. So how much do they understand? What is their response typically to new situations? How do they handle new situations? What sets them off? Are there particular things that the parent already knows will set them off? What calms them? So having these things and having this knowledge beforehand, you can learn about their strengths, their limitations, and previous experiences, what has worked in the past, and better prepare yourself for that visit and come up with a plan. Planning ahead based on what you learned. If they're sensitive to noise, find a quieter area. If they don't like to be touched, ask the parent to help instead of you touching. Have some sort of reward or a particular object or toy that they enjoy. If you already know that, it can make things much more successful. Be familiar with and develop a plan for each child or every individual, and have your staff ready as well to implement that plan. The more prepared everyone is, the better it's going to go. And implement the plan that you've developed, right, with your team. It does take a village. You can't do this alone, right? Everyone has to work together. And that village includes you, your staff, the parents, and the individual, him or herself, right? Being able to advocate also for what they need and for what feels right to them. So this is, again, just a preamble to a fantastic set of presentations that are coming with Dr. Sorensen, but just techniques that might be helpful. One is given a choice. If possible, give offer a choice. Would you like me to look at your right ear or your left ear first, right? And sometimes giving them that sense of control a little bit will help minimize the fact that you're approaching them and telling them what to do versus having them be able to manage that a little bit. Offer some distractions, ask questions about their interests. If you already know what they're really interested in, they're fascinated by trains or fans or leaves or whatever, water tanks, whatever it is, ask questions about it, or use toys or objects to keep them busy if they don't have the ability to respond verbally. Sometimes counting or singing, if language allows, can be also helpful distraction. Use visuals, oftentimes, but not always, people on the spectrum are very visual in their learning and very visual in their understanding. Especially in moments of heightened emotion, like moments of stress. And oftentimes there's kind of language, even if they have it, tends to be not as available during these times. So using a quick reminder like a visual in terms of pictures that help explain the procedures or help explain what's going to be happening in the expectations could be really helpful. Imitation and role modeling is another great technique. Using a doll or something else to show them what's going to happen first, right? A doll and a pen to show how maybe a shot would be given. Or to demonstrate like how a medical device, the stethoscope or any of these things. This is great when there are some imitation skills, like these won't work for everyone, right? It's figuring out what might work for this child, and that's why it's so important to partner with the parent. Role play with a sibling. We had a fantastic case of a physician who reached out to us, who needed to give this very difficult situation. I think he was 17-year-old who needed his vaccines updated and had such a negative prior experience that there there was a lot of skepticism about what was going to happen when he came in. Well, it just happened to be that his brother came in too and had his vaccinations and his shot and just showed him what needed to be done. And then everything worked out smoothly. So sometimes that just watching, and especially if it's someone that that role playing can be really, really a fantastic tool. Another great tip is from an easy request to a difficult request, right? So start with something simple, something that and maybe you can ask the parent a simple instruction that they already know how to do. And then follow it up with something that maybe might be a little bit more challenging, like ask them to do something like show me your ears or touch your nose or something that they would be readily able to do. Don't assume, ask. And then provide something like open mouth and stick out tongue to be able to do your exam. Rewards for compliance, any compliance, try to reward it. Don't assume you know what's rewarding, right? Ask the parent. What you think might be rewarding may be the complete opposite. So make sure that you have that information. Reward any attempt, even if it's not exact or complete, just to get things going. Talk directly to the individual. Don't assume because they have autism that I need to talk to the parent instead. Talk directly to the individual. The parent will let you know if they need to intervene or if they need to provide any sort of assistance. Don't assume they don't understand. Don't talk about them in front of them, right? Just like you wouldn't with anybody else. You either talk with them and they are part of the conversation, or any additional talking should happen without the individual present. Explain briefly and simply what's happening, right? Try to use very specific language and concrete. Language does not determine understanding. And we talked about this before, right? Just because they don't have a strong verbal language ability does not mean that they're not understanding what you're trying to tell them. So ask the parent how much they understand before the visit so you can be prepared. Minimize waiting. Oftentimes waiting is a trigger, right? Because it creates a lot of anxiety around trying to, figure out what's happening and how long this whole thing is going to take. If you're with a child, bend down, get down at their level. Don't just hover over them. Allow them to touch the equipment if possible, right? And to be less fearful of them. Know about their personal bubble, right? How big is that bubble? How close can I get without it being something that's really going to affect them? And an accepting attitude is always, always, always the best, right? We want both parent and individual to feel fully accepted within that environment. So just kind of some final thoughts. Be creative in how you in how you approach your whatever service you're going to provide. Keep your sense of humor. I know it can be challenging sometimes, and we're so pressed with time and schedules and meetings and things that we need to get to that sometimes we're just going about the day. And keeping sense of humor is important. Like our friends here, Fred and Barney, say, life is so much easier with a sense of humor. So let's keep that that way. When possible, prepare in advance, right? The more you can prepare, the better the session is going to be. The parent knows best. Follow their lead. Ask them. They've been with this person day in and day out. They know what helps, what triggers, what calms, how much they understand, all of these things. Use a gentle tone. Lower lights if light sensitive. Think about these things. Lower volume of overhead music if they're sensitive to sound or noise. Remove your lab coat when possible, right? That was something that in the hospital we did not ever use lab coats within our setting because they often do have very negative associations with lab coats. So remove lab coat when possible. Remember that a good experience will result in greater cooperation the next time around, right? All of us will be happy to go back somewhere if we had a good experience. If we go to a restaurant and had a terrible experience, the likelihood that we'll go back is very little. If we go to any provider and we have a terrible experience, the likelihood that we go back to that particular provider is probably very low. So just think about that. If it's like that for yourself, we don't want to force, the child or individual to go to a situation where they've had a really negative experience in the past. So we want to optimize each one of these opportunities. So that's that. I'm going to stop my screen share so that we can have a few questions.
The first question that we have for you is, how might the emergency room or hospital be stressful for an autistic person?
And I know that Dr. Sorensen is going to talk a lot about these things, but certainly an emergency room is a very busy place, right? There's lots of sounds and lights and people, movement, hurried movement oftentimes, right? Things happen very quickly. Not necessarily gently, right? So there's all these things happening that can make it it's a very scary environment oftentimes for any child, but even more so if you're not understanding exactly what's going on or what's expected so that would be a great place to plan for. I know that at Advocate Children's Hospital in Chicago, we had developed a separate room in the ER that was for patients on the spectrum or other neurodevelopmental disorders that needed kind of a quieter space, a space with less around them, from less beeping, less lights, the ability to turn down lights, no real nothing that could be a projectile in any moment, so preparing, making the environment a little bit more sparse, so that if the individual was having a difficult time, we would minimize any risk for the individual and for others. So the ER, I think, can be particularly difficult, but there are some things that folks can do to prepare. And I know much more is going to be said in the coming presentations by Dr. Sorensen, but this is, I think, it's a great question because it's truly one of the areas where there's most difficulty sometimes.
How do we determine if the patient's reaction is due to the environment or if they are hurting or sick?
That's a fantastic question. And, sometimes the best person to be able to answer that is the parent, right? Who will know those cues best and know what different, sometimes it might be in the form of some sort of repetitive behavior that tends to emerge when the individual is stressed or hurt. And the parent will know the difference between that and something different, right? So, I think being an active partner, it needs to be a fantastic partnership between you as provider and the parent. In terms of helping that individual be able to express hurt, pain, discomfort, or just, being able to tease apart that from other things that might be emerging because of that stressful situation. So I think there's, the parent will know best how to get that information from the child or the individual.
The parents that I see coming through the hospital, I think what they tend to know is that their child is way off of baseline, their normal baseline. And I think one of the key things for any hospital provider, whether it's emergency room or inpatient hospital, is to really get the team to learn what is the child's normal, what is that normal behavior, because that is how we determine what's off. And so some kids will be really sick and really docile, and that's so abnormal for them. And so it's a clue, but a provider might come in and say, they're doing great here. And the parent's like, no, this is awful, because they're so far from baseline. So it really is about not assuming, and asking those questions and making sure that you kind of know, because we're all aiming for the child to get back to baseline in a sense. And so we have to know kind of what that is. Even if that baseline isn't maybe as a provider what we want to see, it's helpful to know what their healthy self looks like. I think it can also be different when they're coming in for agitation of unknown origin. So it might be psychiatric, but it also could be constipation, and discomfort that has caused a crisis in behavior. And so it's really important not to just say, oh, their behavior's out of whack, and it's automatically psychiatric. So I think it's just truly not assuming and really doing a really good differential, but getting that baseline from the parent and then trying to determine, what the triggers are for the change, is what I've learned over many years of doing this in kind of emergency hospital settings.
I think that's a really good point, Dr. Sorensen, because it's also like that, not assuming that an out of whack behavior is also just because of autism. Mm-hmm. Yeah. Right? Because, many people who have significant issues with sleep or constipation or GI issues that might be impacting will be irritable, will be less than kind and pleasant, in different situations. And in particular, kids, if they don't have the ability to express that well. And so not assuming that just because they engage in this behavior, it's because of their autism, and just really asking, right? Like, what is that baseline? What is the normal? And if this behavior in any direction is different than what is the baseline, what's normal behavior, what's typical behavior for this child.